Yeah, there we are. Okay, so I have no conflict of interest and no payments. And the okay, come on. Oh, there we are. So at the end of the session, you will be equipped to challenge the belief that age and experience make one wiser. You'll certainly be. Identify the tremendous gains in preventing and treating infectious disease. It'll focus mostly on the preventing part, and advocate for recruitment and retention of physicians in rural medicine. Just my personal perspective, what is attractive in rural medicine. I'll be, there's two stages: the aging doctor, acquired skills and experience versus cognitive decline. And then the issue of this getting older make you wiser. There is a few points there. This preparation for this talk was very useful for me. There was a lot of things that I did not know at all. And may be useful for you when you are reaching my age. And some of it will apply to everyone, as you'll find out. So I'm an international medical graduate from the Netherlands. This is a picture of the place where I grew up. It doesn't show the high rise on the left and so on, but it's pretty nice. So we'll start with vaccines. The smallpox was eradicated in 1980. Vaccines came out with Jenner in 1796. Pertussis took a long time to develop. Diphtheria toxoid and tetanus toxoid was easier. It's a toxoid, a protein. And poliomyelitis took quite a while. Salk vaccine came out in 55, and type 2 poliomyelitis got eradicated. I can't see the right side of my slide, it's covered. How do I get rid of that? I think in 2015 and type 3 was eradicated in 2019. You can probably read it, but how do I get the sidebar away here?
And probably drag it down to the bottom of your screen if you like, Dr. Hak, and then you won't, it'll just obscure the bottom of your screen.
Yeah, good, thank you. Type 1 is still in Afghanistan and a small area in Pakistan. Okay, this is a memento in our family. So I have this at home. It is a little picture kind of a painting kind of thing. And what you see is a grave, and you see a sun, and the hairs of the boy are used for the rays of the sun, and they're also in the front used for the grass. So this is a great uncle of mine. He died from pertussis in 1894, and a young brother of his also died probably during the same pertussis outbreak. My grandma, who told me about this as well, was probably around 5 years old. And she told me the doctor didn't come, the boy had to be, he said, just try and get him fresh air when he is so distressed. And so they were hanging him out the window to try and catch his breath, which of course eventually did not happen. And he just died basically from asphyxia. And it made a deep impression on my grandma. So 2 of 7 siblings died from pertussis. The others all survived. And so he was born in 14 January 93 and died 30th of December 94. So he was not even 2 years old. So pertussis is still a big problem worldwide. There's about 9,000 deaths in the US in 1940, but still worldwide there is about 500,000 deaths. Mass vaccination between 1940 and 50, first in the UK, later in the US, reduced the incidence by a factor 150. So you can see there is very little that is as effective as vaccinations. So in the US, there were only 7 deaths in 2019, and here in Canada, there were, I think, only 1 or 2, is what we have yearly. So the whole cell vaccine is the first vaccine, is very effective. However, there was an increase in febrile convulsions, hyperresponsive hypotonic events, and crying events. And there was a concern because of the neurological features that it could cause damage, brain damage. And this was sort of a controversial issue. And a big paper came out in 74 from Great Ormond Street in London, main children's hospital in England, neurological complications of pertussis inoculation, and this spread like fire. The immunizations just dropped. And since then, many of the alleged vaccine encephalopathy victims were shown to have a sodium channel NA1 defect, which is Dravet syndrome, a rare condition, but which typically would get seizures at the time of the vaccine because they're very prone to seizures. Between 71 and 74 in England and Wales, the incidence dropped, so the vaccination rate dropped with more than 50%. And of course, then there were just outbreaks and literally hundreds of children died. But nevertheless, it took quite a while before immunization rates recovered until the mid-80s. And this happened not just in England, also happened in Canada. In Germany, they quit altogether using the wholesale pertussis vaccine and just put up with the deaths, I guess, and not until the 1990s when the acellular vaccine came out. So pertussis itself causes encephalopathy far, far more often than the vaccine possibly could have ever. And this is just a paper from a 20-year period where they had about 23 cases of encephalopathy dying, and they had a total of 114. So some of these would also be significantly handicapped. And that's just in one city in Germany, in Hamburg. So the cellular pertussis vaccine, most definitely you don't get crying events. Febrile convulsions are not so commonly associated with it, and hypotonic, hyporesponsive events I have not seen. I saw several when we still had the wholesale pertussis vaccine before the 1990s, and they're very, certainly very scary. The child is sort of semi-comatose for an entire day or longer. Because we knew what it was, you didn't do anything, but you know, it was sort of a scary event, which has prompted a lot of the troubles with not vaccinating. So this vaccine needs 6 immunizations by grade 9, and you need some boosters if it's in the community. So worldwide, about 400,000 deaths. We still have a fair bit of pertussis, but deaths are very rare. Most are under the age of 1, particularly under the age of 1 month, where the fatality is about 1%. Much, much better, of course, than in the past. We intubate those babies, and they frequently need treatment for pulmonary hypertension because the hypoxia triggers a return to a kind of fetal circulation, and they get significant pulmonary hypertension. So this is more clinical points. First of all, it's very easy to miss the diagnosis because most of the coughing occurs at night, and they show up in your emergency room or in your office, and the parents are very distressed. But the kid looks fine and is not coughing in your office. So do suspect it when there's an outbreak. Also suspect any case of a cough that lasts more than 14 days and where the child is vomiting or at least gagging or severely choking or has an apnea with the cough. So you have to demonstrate the paroxysmal cough because obviously parents don't know what it is. It is a repetitive cough that just goes on, and at the end the child turns red in the face or blue and has a hard time catching its breath. And when the laryngospasm resolves, which is part of this problem, then as soon as the vocal cords open, the child, of course, breathes in, and that makes a sound called a whoop. So, and then they cough again. They're productive of thick mucus, which is difficult to clear, particularly in babies. And the parents are really very distressed. They're scared. Kid cannot breathe. They are afraid the child will pass out. They're afraid the child will die if they have severe apneas with this. And they're often up several times at night, easily 4 or 5 times at night. They often sleep with a child in a in a recliner. And some nights are better, some are worse, but as it says, it can last about 3 months. So when you suspect a case, but you're not so sure, it's not in the community, the one thing to really ask, is there a child under 2 in the household? Because the presenting child may be 6 or 7 and not particularly at risk of dying. But there might be a baby in the house, and you need to know, because then you have to be much more aggressive with pursuing a diagnosis and also prophylax the little one if there's enough of an indication. So diagnosis with PCR, we used to do pertussis swabs, which you needed a good technique for. You can do a blood test because in pertussis, the lymphocyte count is pretty well always elevated. I've frequently found in the milder cases still a lymphocyte count over 10. And we've seen cases of 50,000 lymphocytes, which is called a leukemoid reaction. And the first time you see it, scares you. You think you're dealing with leukemia, but it's part of the pertussis picture. So azithromycin, even 5 days will stop the shedding. And naturally, there will be no shedding after 3 to 4 weeks in an immunocompetent person. Unfortunately, the antibiotics do not help you in the symptomatology if it's not given right away. So even after 2 days or so, when you treat, the symptoms will go on for a very long time. And they'll come back with the next cold. Of course, there's no pertussis anymore, but they go through a similar hypersensitivity kind of picture with even the whoop and vomiting and so on, and which again can last a while. So this is a picture. This is in relation to diphtheria. This is a picture of an obstetrical stethoscope of my great aunt. I still have this, and we use these things until the 80s, and they're very good actually. You put the bottom part on the mom's abdomen over the fetal heart area, and the top goes on your ear. I'm not sure if anybody ever used those things, but they work quite well. So my aunt told me about this, my great aunt, that diphtheria, when she was working in Germany in the 20s, she could easily recognize because it had a particular sweet, somewhat nauseating smell. So that's how they diagnosed children, because I don't think they could even isolate the bugs at that time. And of course, they had the white sort of plaques on the back of the throat and in the nose when the disease was progressing, and a lot of the kids died. So diphtheria, tetanus, polio is of course in our shots. We will not see diphtheria anymore after the vaccination started. It basically dropped out of sight. Tetanus will always be with us. It's a soil bacteria. It's very rare nowadays. Before immunization, there were in Canada 40 to 50 annual deaths. Polio was greatly feared in its heyday, and every community, even smaller communities, had children who were, paralyzed in one way or another, being in wheelchairs or couldn't use an arm. And when the vaccine came out, there was a huge demand, obviously. The Salk came out in 1955. It was a killed viral vaccine. The stories about these developments are very interesting if you ever have an interest in looking at that. Unfortunately, there was a problem with contamination because there were so many manufacturers and it wasn't well supervised, and there were a lot of children that became ill from a cutter incident and some died. And the shift was then made to the Sabin vaccine. And nevertheless, there was not a big vaccine refusal after this incident because people realized how valuable it was. And ever since, we basically do not see poliomyelitis in the developed world anymore. Okay, one problem that happened with the cutter incident, there were a lot of lawsuits, often considered frivolous, but from the parents' point of view, I'm sure they were not. And what happened was the manufacturers withdrew, and there was a huge shortage in vaccine. And then the US government instituted a no-fault vaccine manufacturing legislation. And that's what I'm sure are aware of, that's happening now. And many people wonder why that is. But it is because if there's such a life-saving and such an important vaccine, and nobody wants to make it, you have to take measures to make it available. So with this legislation, there's also much stricter criteria about the manufacture, the oversight and development, and so on. But as you know, that's still the case. The vaccines that are coming out now have protection by law from lawsuits. So in case you wonder why that is, it's not a conspiracy. I'm sure you wouldn't think that anyway. So these are all the vaccines that came out when I was in med school and after. So I've seen pretty well all these conditions, and you haven't seen a lot of these. And many of them are quite well, severe in their presentation and outcome. So we'll go into that a little bit. As I said, MMR, I haven't seen measles and rubella since 1980. But seen a mumps case once, and it still goes around once in a while. Usually it's football players or some group or hockey players that are in close contact. Varicella is rare. Bacterial meningitis, we saw several cases every year. We saw quite a few deaths. It's a horrible disease. And if the kids survive, they could be deaf or hearing impaired, and some have cerebral palsy. Epiglottitis, you will not see. I mean, there is a form that is run by pneumococcal, caused by pneumococcal disease, but it's not as severe as Haemophilus influenza B. And so all these other conditions, sepsis, osteomyelitis, septic arthritis, ethmoiditis, and cellulitis, most commonly caused by Haemophilus influenza B when we saw it. It's quite a bit more rare. Even lobar pneumonia is not as common because the pneumococcus is not around as much. We don't see severe dehydration as much anymore because the rotavirus vaccine and oral rehydration is widely practiced. One quick practice point about oral rehydration, you should know, and I would imagine you do, that Pedialyte is expensive. So just for getting some water with salt and potassium and bicarb and so on, people pay $12 per liter. And it's really not necessary outside the first 6 months of life. And the point is even that all the children don't like it because the potassium doesn't taste good. And you can give them Gatorade, just give them clear Gatorade. There's 2 studies from India show it works just as well, and it's much better taken by the children. There's a more recent study that diluted apple juice is just fine. It was used very commonly in my training, and then it sort of gotten disrepute that it made the diarrhea worse. And by and large, it doesn't. There is a good study from Toronto that shows that it does not cause any problems, and you can give diluted apple juice for rehydration. So what other trouble did we see, which we rarely see, or at least not as much? So asthma, as of course you know, was very poorly controlled before inhaled steroids came out in the late 1980s. And so we saw lots of admissions. We saw a lot of ex-premature babies who had not been treated with surfactant, and they developed bronchopulmonary dysplasia, as we call it. And we saw a lot of these children in the first 2 years coming in with every single cold. Croup, of course, admitted often because we didn't use dexamethasone. Diabetes wasn't very well controlled. We didn't have any of the more sophisticated measures. And spina bifida, we saw a fair bit because there was no folic acid in the bread. And you basically hardly ever see it anymore, and you only see the very mild cases. So we see more autoimmune disease now, but we don't see them in the hospital very often. And of course, there's a host of other conditions that we do not admit very much anymore. And the other thing is that we used to treat osteomyelitis for 6 weeks on intravenous antibiotics in the hospital. So we were pretty busy with all these things. And say in January, 30 years ago, we had up to 22 children on our peds ward. We don't even have that many beds anymore. Now we may have 10 at any time, and then at least, very often half of them are mental health, which we didn't see anywhere near as much in the past. So that's the difference. I don't actually go into much of this, but encephalitis, which is SSPE, subacute sclerosing panencephalitis, can cause brain damage. And measles, and 9% of the younger children get pneumonia with measles, and we had quite a few in the hospital. And a century ago, measles, diphtheria, scarlet fever, pertussis, and gastroenteritis were the main killers of children under 5. And scarlet fever, for some unknown reason, it obviously still occurs, is not anywhere near as severe as it used to be at that time. Congenital rubella, I've seen where the children end up with brain damage. And so just to give you a perspective, you need to vaccinate 35,000 children to prevent 1 case of death from varicella. However, the disease burden is substantial. It's not something that the lay people have seen. And, when they came out, a lot of people say, well, what's the big deal? Why do you immunize for varicella? Well, because, in tertiary hospitals, we do see children with pneumonia, sepsis, and gangrene on occasion. We also don't expect to see as much zoster after the vaccine. So Haemophilus influenza B definitely is a baddie that we pretty well don't see anymore. And the vaccine is, the vaccine is extremely effective. Right now, there's only about 3 to 4 cases in severe Haemophilus influenza B in all of Canada. So that tells you something. And yes, we saw these things. The meningitis was particularly nasty. I've seen kids that were sick in the evening, and the mom brought this child in 9 months old, and she was basically moribund when she brought her in the morning in my office, and we had to resuscitate the child. Of course, she died. And yeah, we've seen quite a few children die from this. Meningococcus is rare, was always rare. Interestingly, a carrier state was not rare at all. We would swab noses in the old days for no particularly good reason, and we found meningococcus in the nasal swabs in about 1 in every 100 kids. So actually the reason you get meningitis or sepsis from meningococcus is because for some reason the buggy has gotten more virulent, or because you were immune compromised of some sort or other. And so the carrier state was high, but the infection rate is quite low and still is. So a practice point here. So I've seen this. A child comes in unwell, and this particular boy was referred by Dr. Lee, family doctor, who's really on the ball. He had this macular rash, not petechial. He had a macular rash. It was quite spread out, sort of in a random fashion, a little more on the on the limbs in the periphery. And it was just unusual in its distribution. I didn't recognize, there was no gestalt of any sort of condition I knew. It would seem so haphazard and so widespread out. And I pushed on them trying to find if there were petechia, and I pushed on several. And then one of them actually did have a tiny petechia in the center, and off he went to the hospital. And he did have meningococcal sepsis. And the sepsis is quite different from the meningitis in its presentation. Meningitis presents with generally with confusion. I've seen the meningococcal meningitis, kids coming in, they're confused. You know, well, this is one of these experience things. That's just my experience, and that might not be a general thing. Okay, most common in the world is group A serotype in sub-Saharan Africa, the meningitis belt, and I'm sure this is also fading as immunizations are being more widespread use everywhere. Rotavirus, of course, did not kill many children, but there was a large burden of disease. And still, there is about 500,000 deaths worldwide, even today. Just quick check, I have to be done by 11:10, right? Yeah, so I better move on. Okay, so however, we did get quite a few kids in the PICUs in the country because they could become severely dehydrated. And it was tricky. Some of these kids had copious diarrhea. Rotavirus has a fairly typical smell. And the experienced nurses would often tell us, but they could present with paralytic ileus. And these kids would come in, they would have very little in the way of diarrhea or none at all. And they would just blow up their tummies. They would just have abdominal distension. If you took an X-ray, you see all these air fluid levels, and you have to realize if you see the air, that just a mirror image will be fluid. So you can imagine when you see air fluid levels, how much fluid is there, and there's a lot. And these babies would come in tachycardic, tachypnic, you know, 8 to 10% dehydrated, and some of them had very little in the way of diarrhea. HPV, just a very quick word. So I told you that for varicella, you need to immunize 35,000, and it's similar to other conditions before you save one person. With Gardasil, which is a fantastic, fantastic vaccine, you only need to immunize 1,000 women, young girls, to prevent one death. It's actually even less than 1,000. You only need to immunize about 1 in 350 to prevent cervical cancer. So it's really, it was a bit bizarre to me that people would object to this vaccine. And of course, it would be very unrealistic from a parent to say, well, my child will not be promiscuous, you know, and they will never get this. And it's just a kind of reasoning they're sticking their head in the sand. So the influenza vaccine, I won't talk about it. It's not that effective, about 60%, but on the large scale, it keeps people out of ICU. Okay, the schedule is on the Alberta website, alberta.ca, for all the vaccines. Okay, practice point. Try not to use the term anti-vaxxer. Well, I have to laugh because I use the term quite a bit, and it's hard not to in today's climate. Use vaccine hesitancy or vaccine hesitant or vaccine refusing, because it sounds denigrating, right? Anti-vaxxer. Here is a picture of Eckerdale Park, which is near Medicinet. It's across the river there. You have a couple of lakes there. You can swim, boat, and there's a picnic area. There's lots of stuff. Okay, so now about late career physicians, over 60 or 65. We're there, there's lots of us, and more, as a matter of fact. In 2015, this is JAMA of surgery, 23% of practicing physicians were over 65 in this survey. And 30% of pediatricians in Medicinet are over 65. Well, make that 25 on is half time, if you want to see it that way. But yeah, this is reality also in family practice, no doubt. And there's implications, it has implications, and a lot of it I did not realize before I started this talk. So David, thank you for inviting me to do this. I learned a lot from it. So my presumptions were that experience would be extremely helpful. You know, you have experience, and you frequently get asked by colleagues, because you have experience, what is this or that? And you've often seen it or have an approach. So no question that's helpful. We have a more dynamic or longitudinal understanding of diseases because we've seen it for a long time. I've seen Fontaine's surgical procedure, you know, evolve in children over 20 years. And then you see the protein-losing enteropathy, and you see the liver cirrhosis occurring and so on. So unless you know, have followed people for that time, you don't have that picture. So we are more comfortable in our approach, no doubt. We think we can separate relevant from less relevant because we've gone down the garden path so many times. And we're more confident in our own judgment, and that can definitely backfire because you think you've seen it all and you've never, ever seen it all. I remember we had a colleague, he's still alive, Dr. Paul Gelke, practiced till he was 81 and does locums in our hospital, and he would not miss a beat. I mean, the man was so sharp. But I remember I had a case of some condition I thought wasn't all that rare, but he'd never seen it, and he's 81 years old. And so this happens, you have never seen it all. And you have also not seen all the presentations. So we do have experience seeing things go wrong, and the nurses do too, you know. It's always a very good thing to have an experienced nurse on the floor that has, you know, that's on the ball, and it can save your bacon for sure. The patient, pretty, you know, of course, first of all. So you have more experience seeing things go wrong. You might over-investigate just based on your limited experience of what went wrong. So you're not sweating as much when you're called. That's certainly my case. So you're more relaxed because you're not as worried that you're not going to be able to deal with emergencies. If you last this long, you probably know how to avoid burnout and manage stress. I believe that's true for my colleagues as well. I've talked to quite a few older physicians over the years, and we enjoy what we're doing. Your mortgage is probably paid off. You like your job because you're still here. That's generally true. So what is problematic? Your basic training was a long time ago. I didn't know anything about IL-6, and we talked about pyrogens. You know, there was so much in the basic training, which is, you know, 45 years ago. So you can imagine how limited it is for now. So you have to pick up on that. So your memory and processing speed have gone down. You may forget that prescription before the patient leaves. You may not remember details of your conversation or your assessment. So you have to be careful that you write stuff down or type stuff down when you're with your patients. Otherwise, you might forget. You cannot, you're not going to be able to multitask as well. You might take more time to recover from a busy call, and you may have health issues, hearing, vision. Older people generally don't sleep as well, not necessarily, but they do. And energy can definitely be an issue. You will, by and large, become less energetic when you get older. And that is not something you expect, actually, but it's very true. So when this is, there's a whole bunch of bad news here I have to give you, and it implies for all of you, as a matter of fact. Brain decline begins between the 20s and 30s. You didn't know that, eh? Well, I didn't, but if you look at MRIs, MRAs, functional MRIs, regional brain volume starts to go down, cortical thickness, myelin integrity, you get neurofibrillary tangles, changes in your receptors for serotonin and dopamine. And so your peak performance in memory, reasoning, spatial visualization variables and processing speed are in somewhere around the age of 22 to 27. And after that, it goes down. Now, this is from a guy called Salthouse, and you know, it's not him only that has studied this, but some people feel there is a little bit of too bleak a slant on this. Some of our domains remain stable for from 20 to 60 years, and undoubtedly is true. Okay, so decline. Between the ages of 40 and 75, mean cognitive abilities test decline by 20%. So that also shows up in various parts of an IQ test, for example. But if you have more time for the test, you may not do as badly. But if you would do an IQ test at the same speed you're supposed to do it when you're 20, you're not going to do very well. If they give you extra time, you can still do quite okay. There's a lot of variability, of course. Now here's another bad news. Anesthesiologist over 65, a Canadian study from 2014, had 50% more cases of litigation and almost twice the number of cases involving severe patient injury compared to under 51. And the reality is we're not going away. You'll see a lot of older doctors because there is a shortage. And so we have to deal with these very real issues of decline. Older doctors are more likely to qualify as heavy drinkers, also more smokers, also more obese. Drinkers male more so than female. So all of these things. Now some of these, this is from 1991, has changed. Frankly, I don't think I know any colleagues personally that are heavy drinkers. Very few smoke. But nevertheless, it's an issue in some. Australia did a lot of studies on aging in doctors. And again, same things I mentioned earlier: decreased processing speed, problem solving ability, fluid intelligence, decreased manual dexterity, reduced hearing and sight, but there is a wide variation. So for those where manual dexterity is very important, like surgeons, the interesting thing is that surgeons that are somewhat older, but not old, are at the height of their career. They do better than their young colleagues, but once they start to lose manual dexterity, they go down in their skills. So, and we as older doctors are more likely to be reported for poor performance. This was a Polish study, or at least an Eastern European study, and they found significant number of doctors actually had signs of early dementia, and that's not very good, obviously. Okay, so is it true that if you have more clinical experience, you provide better healthcare? And this is a review of 62 reports. And I don't know about the how well these reports are put together, but just look at the trend. So 50%, pretty well, reported decreasing performance with increasing years. And I'm talking about their quality of care. And this was in all outcomes, and then in some outcomes it was still 21%. Only one or two papers showed some actually increased performance. And so this is something that got my goat a little bit. So physicians between 6 to 15 years in practice, which by the looks of it, a lot of you are, they provided the best care. And I thought about this, is this really true? This never dawned on me. And I think it's actually true. It's true for two reasons, I think. First of all, you have sufficient amount of experience that you really know how to approach clinical problems. And you are at the height, or certainly close to it, of your mental functioning, your speed, your ability to reason, and your fluid intelligence, and so on. So yes, I believe it's true, because experience is only going to help you so much. And one thing is very, very simple. You may have all the experience in the world, but if you forgot these cases that you saw, 30 years ago, it doesn't help you one bit, obviously, right? So do any of those studies show anything positive? Well, we are better gatekeepers and less likely to be pushed into writing sick notes when they're not indicated. I'm not so sure that's our age. I think that's also part of the culture. When I grew up, cultural norms were very different. We were more paternalistic as doctors, and so we more quickly you know, pushed or felt to be in a position where we could decide about a patient. And growing up now as a physician, you're more into patient rights, patient autonomy, and you probably don't feel as justified to withhold sick notes and so forth. So that's actually an issue, I believe, because I think people abuse the system, and we as doctors have to resist if we know truly that that's happening. We have lower burnout scores. Well, so the experience I talked about that. And again, the experience apparently doesn't help us that whole much extra. So in Alberta, I think we do pretty good. We have yearly practice reviews after the age of, I can remember, 60 or 65. I certainly have them. We have a peer program. I'm not sure what's happening with it now, but there were, you know, evaluations from coworkers and patients and peers. And so in general, colleagues can most definitely help, and they are accommodating. You know, my colleagues certainly help me to take less call, but I still like call very much. And of course, most importantly is your self-evaluation. Be aware that you are declining, and that's not easy to accept, but it's just a simple fact. So how can you how can you offset some of the risks that that you pose to your practicing? And so first of all, working in a group helps. I totally believe that, and involved in teaching, well, you all know that it helps you. You all know that your residents can put you on the spot. They can ask you, or they know stuff that you simply don't know because you're not trained. You didn't have your basic training at the same time that they do. And so I find it tremendously stimulating to teach, and I think it's a great help. So SIMS, we talked about it earlier. This was particularly found to be the case with the anesthetists. And I find SIMS also, the resuscitation type SIMS, that is, extremely helpful. And they're also not just helpful for teaching, but they're helpful for evaluation. I think if you find yourself in a position where you do not do well on a SIMS anymore, you cannot really think fast enough and act fast enough or instruct fast enough, required in the situation, that should be a kind of a red flag. Maybe you should not be involved in resuscitations or in that kind of acute care anymore. So over time, avoid situations that are too complex because you are not going to be able to multitask as well. And so take less call, plan more time, make sure you do not get overtired. Keep up your learning activities. Well, these are all quite obvious, but practice standards and guidelines. Older physicians like myself, we're less likely to stick to practice standards and guidelines. Well, for what reason? Well, first of all, we've seen them change all the time, and maybe we don't think it's all that important. But also, I think it's maybe not our area of interest. I'm not sure. Certainly the case, I found I was more interested in guidelines in the past. I still am, though, and I really try to follow them, but it's an important thing we need to keep up on. Have a trusted colleague, or maybe more than one, that's willing to tell you your work is becoming substandard. So I think, which also implies that you really have colleagues, that you have good colleagues, that you have good relationships with your colleagues, and that you have an honest relationship with them. Okay, so basically, the things you can do: take more time, look things up, you know that, and keep your interests. I really believe that if everything in medicine is interesting to you, and you look around, you learn around the areas of medicine, that will be a tremendous help. I know from musicians that, I think I'm getting there, hey? From musicians that keep up in their, after they retire, they can play at a level that is unbelievable for an 80 or even a 90-year-old on their instrument. And it's just because they keep going and they find it interesting and stimulating, and you keep your brain cells going, and then they last longer. So how can you counteract the loss of memory? So go over your course material again, write down salient points, frequently go over the same thing, look up cases again, even if you thought you've seen them 5 years ago, go back to up-to-date or whatever, and because you have to imprint more, and then stay healthy. Okay, then the quick question, am I wiser now? Well, that was, of course, that is a rather awkward thing to self-evaluate yourself on. Well, the longer I work in this job, the more grateful I am for this profession. I can certainly say that. I cannot think of a better job, frankly. So humbling in many ways. So one of the most humbling things I find is that if you look after a handicapped child or a child with multiple medical challenges over a long stretch of time, and you get to know the parents very well, and you become sort of a member of their family. In the eyes of the family, you are just a step lower than God. They literally tell you that. And I didn't believe this when they told me that I was such an important person in their life. And I find it scary, as a matter of fact, because I mean, who am I? I'm just doing my job, and they so rely on you because they so need you. It's an extremely humbling situation, and that's the extreme part of it. But even in anywhere where you care for people, and they so appreciate what you're doing, and yet you get paid really well for it. I mean, so that's humbling. The other thing that's quite humbling is that you're going to make mistakes. You're going to make serious mistakes. We all will. Maybe not if you're in administration, but people suffer for our failings. I can certainly tell you that. And so early on, the CMPA was telling us we would never apologize because that would be bad for court. I have never stuck to that, never. I thought it was the stupidest thing, and they've come back from it too. Not just it's morally wrong and it caused problems. So do apologize. Well, carefully, I mean, you don't have to go overboard. If you need help with it, talk to the CMPA, but I think it's important that you let people know that you feel bad about the fact that you've made a mistake. And the other thing about this is, of course, it's very hard to forgive yourself for things that where you hurt patients. It's tough. So there is definitely some redemptive quality if you use those cases for teaching, and the parents of the children where this happened to really appreciate this, because one of the main things they want to make sure is that you understand that you did something wrong and that hopefully won't happen to somebody else. So if you teach it to others, what happened to you, parents are greatly appreciative. I do that right in the office. This patient comes in and I missed, for example, one kid, I missed a heart murmur twice, and she had a VSD, and then she had to be operated on. And the mom suffered because she was feeding this child 12 hours a day because the kid was so slow, and I didn't pick up on this. And so I told the resident, this is what happened. I didn't pick up the kid. Mom told me that the kid was sweating so much. It just went in one ear and came out the other. And so the parents smile, they really appreciate that you use the event to teach others. And there's other cases like that. Okay, so quickly about judging patients. We're all quick to judge, likely, certainly I am. And this is what I learned over time. You're familiar with the terminology, walk a mile in their shoes, but the opposite is true as well. So if, we're very privileged people, we had the opportunity, we had the mental capacity, that's not our own doing, to do this job. So what if the person, that we feel we should judge was in our position? Maybe they would have done better than me, So there is really very little reason to judge a person. I'm not saying people should be not held accountable for their actions or their choices. That's not what I'm saying. But to actually deep down judge a person, what is the reason that you do? So confirmation bias is very strong. It's something that I learned to really be aware of. Medicine is absolutely full of this. If all you have a hammer, everything starts looking like a nail. And when there is the need to do something, we can be very hurtful. So there was this issue with lobotomies. If you don't know about it, you can look it up. That went on for about 20 years. And then in counseling, there was this thing called repressed memory counseling. Some people actually, honestly, are still involved in it. It's hard to believe, but it ripped families apart. If you want to know more about it, there's a lady, Elizabeth Loftus, Loftus. If you come across repressed memory counseling, read her stuff, and you realize, how detrimental that counseling was to families. Okay, so am I more vulnerable? Yes, because I feel more secure in my job. But however, do not lose your boundaries. Sorry, I think there was one more thing there. How much time do I have? 5 minutes, or am I done?
You're coming up against the end, Dr. Hack, but you can take an extra 5 minutes and we'll just adjust the time of the next session. No problem.
Oh, well, I'm almost done anyway. So one thing I would recommend is that you study common psychology. First of all, I learned a lot of it for my own family. Family dynamics play in every family. And some of that, I was completely unaware of some of the dynamics in my own family. And if you study family dynamics or you pay attention, and you see there can be power issues, there can be allegiances, there can be issues that cause friction and that are not ideal for your family, that you can definitely can, if you're aware, can deal with. It's good to learn about anxiety, and frankly, it's good to learn about your own anxieties. We can all benefit from, relaxation breathing techniques, and it's good to know to teach our patients this. It's good to learn more about depression, which I was completely ignorant about during my training. And I was very judgmental about a colleague, and I still feel ashamed. When she committed suicide during my training at Sick Kids Hospital, I thought she was so irresponsible. I just was completely clueless what depression is all about. But what about borderline personality disorder or patients that are close to that category? It's a very important thing to know about. Okay, and then this is some red cliffs in Radcliffe near Medicine Hat. Nature around here is absolutely beautiful. And as far as why did I start rural practice? I arrived in '86 here in Medicine Hat because I needed, my wife and I, we needed our landed immigrant status. And we were going to go back to Ontario because we loved, and I still do, love the lakes and the woods of Northern Ontario. But we stayed, and I talked to many, and this is a common story actually. Because once you get, see the lifestyle and the environment here, you don't want to go back. And I'm very happy that I didn't. I'm fairly sure that I'm happier here than I would have been back there. Pace of life, it's quite, we're friendly. By and large, people are more personal. This is more family-oriented community than the larger community where I was. So as a rural doc, you take, certainly as a specialist, but I think as a family practitioner as well, you take care of sicker patients, more complex patients. Certainly, for example, I see a lot of children with hemophilia. And in Calgary, if they would have a bleed, they'd go to the emergency rooms in the Children's Hospital. Here, of course, they don't want to travel 3 hours. They go and see me. I talk to the specialists there, how much factor shall we give? This is what I found, this is what I do. And I've done it for 30 years pretty well. And so they trust my judgment, which is very nice as well. We have a very good relationship with the specialists of the tertiary centers. So you practice at a more responsible level in some ways. And I find that extremely gratifying. And then nature. So you're more close to nature when you're in a smaller community. So Cypress Hills here is 45 minutes away. And the coulees, the prairies, the river, we live close to the river, and I walk every day with our dog. This is also interesting. These are dinosaur bones I picked up in various places. You see a little vertebra, a tiny little shoulder blade. There is a little toe. There is a piece of a tooth of a pretty large predator, because that's 2 centimeters, only the tip of the tooth. And you can find those here. And this is remind you of the history of this area. This is a TP circle, as you can see. This one is even on Google Earth. I can give you the coordinates if you ever want to go there. Just email me on my Alberta Health email. And this is our puppy, our doggy, Jake, who loves to come along. And there's a lot of history about these and what kind there are. And just between Medicine Hat and Radcliffe, I found 7 of those quite easy, and a whole bunch of disturbed ones around there as well. So there was a lot of history here related to the first inhabitants. And this is getting to the end. Nature, exposure to nature, and I feel quite strongly about this, is extremely valuable for your mental health. More so than just relaxing. Just being out there and being surrounded by nature, it's extremely therapeutic. and I can highly recommend it. And there's quite a bit of literature now on this. And this is my last slide. And this is Elkwater near Medicine Hat, a beautiful area. Thank you.